Quinlan is a very active female. She's a three-sport athlete and especially enjoys playing basketball. Although she's in excellent shape, she does little strength training. She has no major medical problems and has not experienced any major injuries during her career. But little did she know, a fun day of shooting changed her basketball career forever. Let's join Hannah and take a look at that faithful day. Before discussing Hannah's injury, let's look at a diagram of a normal knee and identify the major bones and tendons that make up this joint, the tibial-femoral joint. Number 1 is a quadriceps muscle. Number 2 is the femur. Number 3 is pointing to articular cartilage. Number 4 is the lateral condyle. Number 5 is the posterior cruciate ligament. Number 6 is the anterior cruciate ligament. 7, the lateral collateral ligament. 8, the fibula. 9, tibia. 10 is the quadriceps tendon. 11, the patella. 12, the medial collateral ligament. 13, the meniscus, and 14, the patella tendon. Makes a note, which is not visible at this picture, but crossing the top of the lower part of the MCL is the location where the joint tendons of the serratus, gracilis, and semitendinosus muscles meet. This is named the pes anterius. Now, because Hannah received such a strong force to her knee from the lateral side, and her foot was still planted on the ground, her knee went medial while her tibia went the opposite way. We call this valgus load to the knee. It appears that Hannah has suffered a blown knee, which we can also term the unhappy triad. Let's focus on 3 structures that were affected by this injury. Number 1 was the ACL, which originates from the lateral epicondyle on the femur and inserts on the intercondyle eminence of the tibia. Also, the medial collateral ligament was injured, which can be called the MCL. This originates on the medial femoral epicondyle and inserts on the medial tibial condyle. And this also helps to restrict the lateral motion, which we saw in Hannah's knee, called abduction or valgus load. The third structure that was damaged was the medial meniscus. The medial meniscus is a fiber cartilage structure that spans the knee joint medially. It's located between the medial condyle of the femur and the medial condyle of the tibia. This meniscus attaches to the tibia on the intercondyle fossa in front of the ACL. The posterior end is attached to the intercondyle fossa of the tibia between the attachments of the lateral meniscus and the posterior cruciate ligament. It is more susceptible to injury and is not as mobile as the lateral meniscus because it is fused with the tibia. Now let's take a look at one of Hannah's potential x-rays. Number 1 you can see is pointing to her torn ACL. Number 2 is pointing to the patella tendon. Number 3 the patella. Number 4 the medial meniscus. 5 the femur. And 6 the tibia. Hannah now experiences more motion than she usually would. She can experience pain or no pain, and depending on the type of injury, how mobile she can be. So, we might be asking, how did this happen? Again, the injury that Hannah experienced is called the unhappy triad. It occurs most with contact injuries. All 3 of these structures, discussed before, the ACL, MCL, and medial meniscus, have been damaged. Because Hannah received a strong force to the lateral side of her knee, it generated a great amount of stress on both her ACL and MCL. So you may be asking, why all 3 of these structures? As your knee starts to go medially, like shown in this picture, your ACL easily tears. This no longer holds your knee in place, so your femur and tibia produce a force towards each other, which compresses the meniscus in between them, which was the medial meniscus. All that remains is that your MCL, which cannot withstand the continued force, so that also tends to tear. So, what is the treatment? Well, Hannah can go see the doctor, and the treatment suggestion might be that the ACL can be repaired, but it might take several weeks for the swelling to actually go down. Unfortunately, it does require surgery. Doctors can use a cadaver allograft or a portion of the talar tendon or hamstring and use it as a donor source to make an ACL. The trouble with this is that they may not have as much motion as they used to with their ACL. The meniscus, on the other hand, can also be treated. Large tears to the meniscus may require surgery or removal. If the meniscus has removal because of intense damage, the patient has increased risk of developing osteoarthritis in their knee later in life. So why are women at risk? According to a study performed at Indiana University, female athletes are prone to more injuries of the knee than their male counterparts because they actually tend to have an inward valgus position, like described before, when they land, stop, or even change direction of their movement. Due to the fact that they are already in the position, if a force is applied to this, they are at greater risk of tearing the ligaments that are trying to hold their knee against the lateral load. In this study, they compared male versus female in prepubescent and postpubescent individuals. The results showed that in both male and female in prepubescent years, they both had a valgus knee position. But postpubescent females continue to have valgus knee positions, and males showed more varus knee positions, which is the opposite. So now that we know that females are at greater risk for knee injuries, what can we do? So ACL prevention should begin in the early years of female athletes. Strength training for lower extremity muscles, including even the ankle, should be the main focus. Females should also be more aware of their knee positions when landing. It is important that continued research is done on strengthening the knees, especially in young females, so athletes like Hannah can continue to pursue their dreams and aspirations injury-free.